I just want to say that I can read Gopal's slides here. And the first slide says, "Good morning, and thank you for that kind introduction."
Yeah, you're introducing me.
Yeah, yeah. Um, so I guess I'll change my introduction. Um, anyways, there are a few things that I realized in introducing Dr. Lal Chandani this morning. Number one, he is not one but two hires from our mentor college. So we are the only college that has hired back two of three of our residents. So both him and Kevin are joining our faculty, which is amazing. But I have obviously known Gopal for a very long time. And a few things that I just found out this morning was that he was college classmates at Cal with Bobby and Fabian, which I did not know that. So there you go. There's a little tidbit of information, but we were super excited to recruit Gopal back to work with us. Not only as he's a fantastic surgeon, he is an avid researcher, and I have gotten so many comments about how the residents have had a wonderful time working with him the last, I don't know, year, right? Almost a year since he's been here. And how excellent of an educator he has been, and what a great addition that he has been to our department. So we're really excited that we were able to snag him back. And he's going to talk to us today about shared decision-making in upper extremity trauma.
So thank you for that not so kind introduction. I feel like usually when you get up here, you're like, oh, what's the next thing? So today I'm discussing shared decision-making in upper extremity trauma, and I have no disclosures. So why talk about shared decision-making? Well, I'm fortunate to be back and care for a diverse patient population with a diverse amount of pathology in the upper extremity. I thought that subjecting a bunch of non-hand surgeons to my hand surgical interest may be torture. And I also realized that one consistent challenge across the field of hand surgery is when and how to make a decision. In modern day American healthcare, shared decision-making is used with ease to justify when and when not to operate. And I wanted to understand how often we're doing this process and if we're doing it appropriately. And if not, if there is surgical variation that is due to surgeon preference rather than patient preference, then is shared decision-making just sort of the new politically correct term that we use when deciding, what we as surgeons would like to do for our patients? And so for better or for worse, Dr. Andrew Schmidt recently talked about some of these topics and was our visiting Abbott professor last week. And he showed the same exact slide, which shows data from the Dartmouth Atlas, and it demonstrates that there's notable variation nationwide when it comes to the treatment of various fractures in musculoskeletal care. And there's multiple possible reasons as to why variation exists across the nation, whether it be variation in fracture severity, variation in diagnostic intensity, or the rate at which we get advanced imaging for certain fractures to identify operative indications, or the variation of availability of surgeons within geographic area. But it's also clear that fractures of the upper extremity account for a wide amount of this variation, as indicated here. While these data are from a few decades ago, the near universal surgical treatment of hip fractures remains, as well as the clinical variability in the treatment of upper extremity fractures. And so clearly, if there's substantial variation in surgical versus non-surgical treatment for upper extremity injuries, and there's an element of urgency in traumatic injuries of the upper extremity, then this poses a unique challenge when eliciting patient preferences and making a treatment decision in our new world of personalized healthcare. And just by briefly looking at the topic of shared decision-making, this is an increasingly popular topic. And a brief review of shared decision-making in PubMed reveals that there has been a huge spike in interest in the last decade in shared decision-making. And so, as a disclaimer, before getting any further, I think much of the following discussion will be based on very limited evidence and also a number of studies from the field of psychology. Okay. And this is a huge topic, and I've tried to focus in on traumatic injuries of the upper extremity. There's clearly thousands of papers on this topic, and so I'll try to highlight a few that will be generally useful. In addition, I'll try to bring up a couple of cases of shared decision-making in the upper extremity to emphasize opportunities to engage patients in their decisions. My goal is not to get into the weeds of any given controversy, but rather to explore the pressures that physicians and patients face when making clinical decisions. And overall, I hope that this topic is pertinent to the daily practice of many of us who are either surgeons, proceduralists, musculoskeletal providers, future surgeons, or even as patients. So in order to do so, plan to start off by discussing a few case examples and then review some of the background on shared decision-making. I'll then get into the psychology of decision-making, some pitfalls that may limit our shared decision-making, and areas for improvement. So to start off with the case, one area of controversy in upper extremity traumatic injuries is how to manage a traumatically amputated digit. In this case, a 35-year-old right-hand dominant healthy horse ranch manager presented with a left index finger traumatic amputation from a chop saw accident. He, at baseline, runs a horse farm and denies any smoking or illicit use. And pictures of his injury from a referring facility revealed a oblique traumatic amputation of the index finger through the middle and distal phalanges. From a bony standpoint, preoperative radiographs showed a complete amputation through the phalangeal neck, the middle phalangeal neck of the left index finger. And decision-making on replantation versus revision amputation is a complex and controversial topic. And while indications themselves are controversial and often based on expert opinion, a zone 1 injury such as this is a relative reason to consider replantation, but on the flip side, adult patient with an isolated border digit amputation is a relative reason to not consider replantation. And so when patients come to a replant center, preoperative counseling is critical because there's strong evidence that suggests that patients have an earlier return to work with revision amputation. And on the contrary, replantation carries higher medical and surgical risks, higher risks of needing surgery in the future, an increased need for a transfusion, a longer hospital stay, and even after all that is done, poor sensibility and motor function after replantation with viability rates that are at best 80%, and motion average is about half of normal. And furthermore, for patients undergoing a replantation, they often stay in the hospital for an average of 10 days and are about 7 months on average off of work. So many surgeons, when counseling patients with this type of injury, counsel them that they would pick a revision amputation for themselves. But in this case, the patient, of course, had a strong preference for replantation despite knowing all of these risks. And so the patient was in the hospital for a week, and clearly these images from post-op day 4 demonstrate a perfused but clearly abnormally appearing replanted digit. And after months of therapy, 3 months of therapy and rehab and wound care, he ultimately had a healed replanted digit with poor sensibility but relatively good motion given his adjacent joint was uninjured. And at a 1.5 years post-op, he reported that he was thankful he had his digit replanted and was doing well. But this type of thought process is limited because the patient never experienced the easier recovery of a revision amputation. However, it does show that in this case, replantation can bring satisfaction to a single patient. Another area of controversy is the treatment of geriatric distal radius fractures. In this case, a 66-year-old relatively healthy former librarian presented with an acute distal radius fracture to another surgeon who strongly recommended open reduction and internal fixation, given the patient was a high demand and relatively healthy 66-year-old. However, injury radiographs revealed a minimally displaced distal radius fracture with 3 millimeters of shortening, which is borderline for operative management in a young, high-demand patient. However, this patient, after discussing with another surgeon, was concerned that they would be at risk of developing ulnar-sided wrist pain with non-operative management. However, there's multiple high-quality randomized controlled trials that demonstrate no difference in patients between non-operative and operative management in geriatric patients when it comes to looking at long-term outcomes in patients aged over 60 or 65. But they do also show a benefit of surgical management early in the follow-up period, and this difference disappears by about 6 months. So based on discussion with her surgeon, and given she desired a minimal benefit of an earlier recovery and avoiding a risk of or a chance of having persistent wrist pain, she ultimately underwent open reduction internal fixation. And even though by 3 months post-op she was healed and had full motion, these types of cases make me personally wonder how much benefit was added to this patient's life with surgery compared to the natural history of this injury. And I think this brings into the question of surgical variability, as I think many people look at the same injury and come to very different conclusions about the benefit of surgery. And our very own Dr. Lauren Shapiro is a thought leader on this topic and has recently published one of the most read articles on the clinical practice guidelines for distal radius fractures. And these guidelines emphasize that for geriatric patients, multiple high-quality studies suggest no difference in terms of long-term outcomes between operative and non-operative management in terms of just geriatric patients and their patient-reported outcomes. However, other studies, including this study published in JVJS in 2009, suggest that there is a wide amount of variability nationwide in terms of operative treatment of distal radius fractures. And so clearly you can see there is a huge regional difference in terms of the rate of surgical fixation for distal radius fractures. And while we know that clinical practice guidelines report no difference between operative and non-operative management when it comes to long-term outcomes, we do know that physician-specific factors account for a significant difference in terms of surgical intervention rates. So in this study published in JAOS, surgeons who had a certificate of added qualification of hand surgery had a higher rate of surgical fixation for distal radius fractures. And while you may critique this specific article or this specific study for not controlling for injury severity, in another study published recently in JHS, authors sent 14 vignettes of 72-year-old patients with distal radius fractures to 185 orthopedic and hand and trauma surgeons. And they found that surgeons on average had a higher rate of recommending surgery for patients with fewer comorbidities and a higher functional status, as you may expect. But they also found that surgeons employed by hospital or healthcare systems were significantly less likely to recommend surgery compared to those who were employed in a private practice model, and the odds ratio was 0.42. So this brings us to the question of surgical variation. And variation in rates and types of treatment can be found amongst surgeons. But using the words of David Ring, the chair of the AAOS Patient Safety Committee, he wrote, "We as orthopedic surgeons might judge the effectiveness of the shared decision-making process in terms of decreasing surgeon-to-surgeon variation. If we are accurately identifying our patients' preferences and merging them with best practices, then variation should be patient-to-patient rather than surgeon-to-surgeon." So this brings me to a couple of questions about shared decision-making. First of all, is it beneficial? Is it commonplace? And is it consistently utilized? And secondly, how do we ideally participate and encourage shared decision-making if it is beneficial? So the first question is shared decision-making an actual benefit? In a meta-analysis of all existing literature on shared decision-making published in 2020, investigators found that shared decision-making in surgery was associated with greater quality of patient satisfaction and less decisional regret. And this led to increased knowledge of patients about their decision. And while shared decision-making is associated with improved patient confidence, compliance, and participation in their treatment, it is also associated with increased patient satisfaction after their visits. Specific to the upper extremity, small studies suggest that older patients with distal radius fractures prefer a shared approach to decision-making. And investigators out of Boston recently tried to understand if there was any difference in terms of disease-specific quality of life. They looked at patients who, at 1 and 6 months out from their visit with an orthopedic trauma specialist, and they found that patients reported increased satisfaction at about 6 months after a shared decision-making encounter, and also reported improved disease-specific quality of life when looking at various injuries of the musculoskeletal system. So when was shared decision-making sort of conceptualized? This was first conceptualized in a report in 1982 in President's Commission for the Study of Ethical Problems in Medicine, where shared decision-making was described as an embodiment of patient-centered care. In a 2001 report, the Institute of Medicine published the Crossing the Quality Chasm, which recommended redesigning healthcare processes to encourage shared decision-making. And more recently, the 2010 Affordable Care Act raised significant interest in the process of shared decision-making by incentivizing the utilization of patient decision aids. And so this term shared decision-making was defined initially as active participation by all parties, sharing of information about values as well as facts, and an agreement on a course of action to be implemented. In terms of a background on shared decision-making, historically, decisions in medicine were initially described as following a paternalistic model, where decision-making was dictated by the physician. The one-way flow of knowledge and decisions was controlled by the physician with minimal patient input. In theory, an informed model is the opposite, where patients are informed by healthcare professionals, and then patients ultimately make an informed decision. And in theory, a shared decision model is a theoretic balance between the two models. And shared decision-making in the healthcare setting is defined as incorporating patient values and coming to a shared decision after a discussion between patients and surgeons. I think in general, shared decision-making is important to increase and is associated with increased patient satisfaction in all areas of healthcare and is also associated with less decisional regret. But it is particularly utilized or cited in areas of clinical equipoise or preference-sensitive conditions. However, for many situations where there's particularly not one specific benefit, there's the benefit of shared decision-making can ensure that patient care plans align with patients' preferences and values. So before discussing if and how shared decision-making is utilized, it's important to understand how patients make decisions when faced with options. So I wanted to briefly discuss some of the psychology around shared decision-making. And to do so, one of the preeminent minds on the psychology of decision-making and judgment is Daniel Kahneman, a professor of psychology at the Princeton University. In Thinking Fast and Slow, Kahneman summarizes decades of psychology research and theorizes that humans have two types of decision-making. So System 1 decision-making is an intuitive, fast, and often accurate type of decision-making where patients use their first instinct to come to a decision. The problem is that this can often lead to an incorrect conclusion, and it's difficult for patients to actually identify whether or not they have reached an incorrect conclusion. Furthermore, this model of reasoning can lead patients to a conclusion that is difficult for them to identify and often relies on shortcuts and pattern recognition. On the flip side, System 2 reasoning is analytic, reliable, and safe, but also time and resource intensive. So one of the challenges in the setting of upper extremity injuries and just traumatic injuries in general is helping patients take time pressure off of their decision-making so they can engage in a more analytic and thoughtful decision. So one important concept in patient psychology after traumatic injury is how to deal with the traumatic loss. The landmark article on the psychology of dealing with loss was published by Daniel Kahneman himself and his colleague Amos Tversky in 1981, where students from Stanford University and the University of British Columbia were asked about a number of questions in a hypothetical setting. And I'll warn you that the scenario that they posed to these students has not aged well 4 decades later. But the setting they posed was, imagine that the US is preparing for an outbreak of an unusual Asian disease, which is expected to kill 600 people. 2 alternative programs have been proposed to combat this disease. Assume that the consequences of each program are as follows. So if program A is adopted, 200 people will be saved. And if program B is adopted, then there is a 1/3 probability that 600 people will be saved and a 2/3 probability that no people will be saved. Which of the 2 programs would you prefer? So in this scenario, even though the expected value of both options is equivalent, decision makers tended to prefer the certainty of 200 lives saved over the gamble when the outcome was posed as a gain. They then posed this following prompt to another group of students, 155 students. So if program C is adopted, 400 people will die. And if program D is adopted, then there is a 1/3 probability that nobody will die and a 2/3 probability that 600 people will die. And in this case, a majority of people selected program D. And so interestingly, this prompt again involves the same loss or gain of life as the first prompt, but decision makers tended to reject the certainty loss of life and instead accepted the riskier option when both options involved loss. So these examples demonstrate the concept of loss aversion, where participants are more willing to roll the dice in order to avoid a loss. This also reflects a bias due to framing effects, in which the context and phrasing of a scenario can drastically influence a person's choice. And this type of loss aversion psychology has been cited as a reason as to why patients will be willing to accept a risky treatment such as replantation in order to avoid the certain loss of a body part. In another psychology experiment, 187 UCLA undergrads participated in a study where they were offered 3 brands of popcorn. And participants had limited options in one group because brand C was sold out. And so participants who did not have all three brands available to them reported a significantly lower satisfaction in their decision-making process when all options were maybe not open to them, even if it did not impact their ultimate decision. So this psychology also applies to patients who often have expressed frustration when certain treatments, such as replantation, are not offered to them, whether or not it may impact their ultimate treatment choice and their ultimate outcome after all that. And so another concept in terms of making decisions, particularly when using System 1 or fast intuitive thought processes, is the challenge of heuristics. And so clearly there's certain factors in the psychology of decision-making that impacts how patients make decisions and how satisfied they are with their decision-making. And heuristics are mental shortcuts that patients and surgeons use when making decisions. While they can facilitate and allow for a quick System 1 decision-making, they may make analytical thinking more difficult. I'll review 4 pertinent heuristics to help demonstrate how they may impact patient decision-making. So anchoring is the tendency to base ultimate decisions based on the first piece of data. For patients who see an obvious deformity of their wrist, they may initially see this appearance of their own body and worry about the potential loss of function if treated non-operatively, and it may be difficult for them to imagine a successful non-operative result. On the flip side, for healthcare professionals who see an obvious surgical pathology on X-rays before seeing a patient, they may find it difficult to then consider non-surgical measures when getting further data on the patient. This would be an example of the anchoring heuristic, where the first piece of data or each picture may impact your ultimate decision. Another important heuristic is representativeness, or the tendency to ignore statistics and instead focus on stereotypes. A good example of this tendency is the term the Bhandari paradox, which our visiting professor mentioned last week. In this study, Dr. Bhandari studied patients who were at risk of a femoral neck fracture and asked if what their thoughts were about hemiarthroplasty versus total arthroplasty. And interestingly, of the patients surveyed, 93% of them felt that they would prefer a total hip arthroplasty given their perceived functional status. And this was equal to the existing rate at the time of 93% of surgeons who are preferentially treating patients with hemiarthroplasty over total hip arthroplasty, given their perceived perceptions of patient functional status. Thus, both patients and or surgeons alike are at risk of ignoring statistics and instead focusing on stereotypes. Patients may overestimate their functional status after such an injury, and surgeons may underestimate the functional status of a patient who recently sustained a hip fracture. The truth is likely in the middle, but these details reveal a downside to System 1 thinking. Another heuristic is the availability heuristic, where people and patients estimate the likelihood of an event based on the ease upon which it comes to mind, or its availability. As an example, if I were to ask you how many words in the English language start with the letter K, and how many words in the English language have the third letter as a K, most of you listening could only think about words that start with the letter K. In reality, there's actually about 10 times as many words that have the third letter as a K, but they're much harder to identify. And in a healthcare setting, for a patient who's waiting in a doctor's office, where each wall and each patient information pamphlet says surgery, it may be difficult to leave a well-intentioned and comprehensive shared decision-making discussion, and a patient may leave such a discussion thinking they need surgery at a much higher rate given the availability heuristic. And finally, another important heuristic that impacts healthcare decision-making is the affect heuristic, or the tendency of people to assess probabilities based upon how they feel towards particular options. People judge an option as less risky if their feelings towards that scenario are favorable, and people judge an option as more risky if their feeling towards the same scenario are less positive. So as an example, if a patient were to meet a well-liked and well-rated smooth surgeon who they feel positive towards, they may underestimate their surgical risks because they feel a favorable opinion of their surgeon. So what are some pitfalls that make shared decision-making and difficult in the healthcare setting? So I think the most commonly cited pitfall is time, right? And time constraints are the most frequently reported barrier to clinical change, including shared decision-making. While existing literature in the field of orthopedics is split, and some studies suggest there is no difference in consultation time when using a decision aid in hip and knee arthroplasty, other studies in both other fields of medicine and throughout the field of orthopedics suggest that higher quality decision-making discussions do require increased time. Additionally, the issue of traumatic injuries can add an element of urgency for both patients and surgeons to come to a decision sooner. For semi-elective urgent trauma, both patients and surgeons may base ultimate decisions on the risk of future displacement and also based on OR access rather than the true risk of displacement at that time. Another pitfall in surgical decision-making is the term overconfidence. So when psychologists ask members of the population if they are better than average drivers, more than 90% of people feel that they are better than average drivers. Clearly, this cannot possibly be true. And particularly if you take a drive through our city, you'll know that this is not the case. But such overconfidence also impacts surgeons. Surgeons feel that their individual surgeries are more successful than the broader evidence. In a survey of 242 orthopedic surgeons, they found that none of them consider themselves below average diagnosticians, and 25% of the surgeons interviewed consider themselves to be a top 5% surgeon. And when interviewing all orthopedic surgeons at a single Australian teaching hospital, investigators interviewed 17 out of 20 total joint arthroplasty surgeons. And they found that of the 20 they interviewed, 17 of them felt that their patients achieved a clinically meaningful improvement more commonly than what they knew was true in the literature. So clearly, surgeons can rationalize their decisions based on and decision to operate based on what works in their hands. This type of rationale can be subject to heuristics, including the availability and representative heuristics, as surgeons may be more likely to have the availability of seeing their own positive postoperative results, and they may not see as many successful non-operative results as well. Another pitfall in terms of making decisions with patients is health literacy. So health literacy is defined as the degree to which individuals have the capacity to understand health information and make decisions. Lower income, advanced aged, lack of insurance, and primarily speaking a language other than English are all factors associated with lower levels of health literacy. Conversely, higher education has been shown to increase patient self-advocacy, and clinicians report a greater understanding of presenting concerns. So, of course, patients with limited health literacy would also like to maintain an active role in decision-making, and so this clearly is a barrier that can make shared decision-making more difficult. When reading about shared decision-making in healthcare, the general consensus is the biggest obstacle to shared decision-making is the fee-for-service system, which creates disincentives for physicians to spend substantial time emphasizing the benefits of non-operative management. In fact, Dr. Schmidt, our visiting Abbott professor, recently brought up this topic of organizational bias. And I think it's important to consider what our organizational bias is. In some systems where OR access is limited, physicians are biased towards not being able to provide care even if they want to because of limited access. Meanwhile, in other systems, easy access to advanced imaging and the concern about not having early access for traumatic injuries can cause physicians and surgeons and patients alike to opt for operative management rather than non-surgical management. And as a result, the concept of a surgical double standard has emerged, where investigators from the Harvard Med School studied if surgeons treated patients like themselves. In this study, 254 orthopedic, trauma, and plastic surgeons with an interest in upper extremity conditions were randomized to choose scenarios based on certain vignettes, either for themselves or another half was randomized to vignettes of patients with the same age and gender as a physician reading the case. And so they noted a trend across all cases described for recommending surgery for patients over themselves. And a significant difference was noted in these cases. Overall, when looking at all topics studied, they found that surgeons were slightly more likely to recommend surgery for a patient than they were for themselves. And they found that surgeons were more likely to choose for themselves with a little more confidence. While this second point is to be expected, given surgeons were making decisions about themselves rather than a hypothetical patient, I think this first point about surgeons being slightly more likely to recommend surgery for patients and themselves is an indictment of our field. And I think there's multiple costs to inadequate shared decision-making. So first of all, many proponents of shared decision-making cite that adequate shared decision-making can help spare financial costs of potential unnecessary procedures. However, this has not been consistently borne out in shared decision-making literature. And I've hopefully provided a couple of examples of patients who preferred more resource-intensive options over resource-limited options based on their preference. However, if surgical variation and variation decision-making is due to surgeon-to-surgeon variation rather than patient variability, then we risk losing our decision-making to payers or having other influences deciding for us when surgery will be helpful or when surgery will not be helpful. And I think most importantly, public trust in our recommendation diminishes as there is more surgeon-to-surgeon variation. In this recent article published in the New York Times entitled "Considering Bone and Joint Surgery, You May Not Need It," which actually includes comments from our very own Dr. Sam Morshed, the author Nicholas Bakalar comments on a recent review of level 1 evidence that on multiple orthopedic procedures published out of the UK. And he, after reviewing these articles, argued that multiple proposed surgeries in orthopedic surgery may be no benefit than non-operative care. While this type of article is likely oversimplistic and the potential loss of trust in our recommendations from the public is concerning. So this brings us to room for improvement. How can we get better at the shared decision-making process? So before understanding how to improve the shared decision-making process, I think it's important to verbalize and understand the steps to an appropriate shared decision-making process. So the original 3-talk model was described in 2012 on how best to participate in a shared decision-making discussion. The first step, as you may imagine, is team talk, working together and acknowledging that there is a decision to be made, and then following up with describing the choices and offering support and asking patients about goals. The second step is option talk, or discussing the alternatives using risk communication principles. This requires knowing and understanding the best available evidence, but it also requires that risks are discussed in a careful manner, as patients can clearly change their decisions based on how risks are described. And while the third step is, of course, making a decision, some advocate for a fourth step, and this involves understanding the patient's wishes to make the decision and also a follow-up to the decision, as some patients, even after an extensive discussion, can still have decisional regret and want to revisit their decision thereafter. Another important aid to shared decision-making is the concept of a decision-making aid. And a well-designed patient decision-making aid provides actionable information on the risks, benefits, and burdens of treatment options and helps patients identify their preferences. In a study published out of the Washington University in St. Louis, elderly patients with hand conditions preferred a collaborative approach when making decisions, and a majority preferred to receive written communication and decision aids. In theory, an ideal decision aid should be written at an appropriate reading level for patients with variable English health literacy, and also in multiple languages to help allow for care of a diverse patient population. For instance, in this example of a patient decision aid, patients can read about a displaced distal radius fracture and understand the rehab and non-operative management versus the risks of surgery. A balanced presentation of options can also help facilitate shared decision-making. And there's also clearly room for improvement in the electronic medical record. For patients who sustain a traumatic injury at a referring facility, as is common in our institution, integration of electronic medical records can allow for coordination of patient care. Also, early delivery of patient aids can help allow patients to start to understand their traumatic injuries and how they can best maximize their recovery, either with non-surgical or surgical management. Also, patient-friendly portals can help facilitate patient understanding rather than just allowing patients access to their care. So current patient portals are structured in a very similar format as the EMRs that we use, and the results are often reported to patients as with notable medical jargon that is impossible for a patient to interpret, and sometimes hard for us to interpret despite years of training. So in theory, if there is a system that allows patients to access their care in an approachable way, it could also help with shared decision-making. And finally, in our post-COVID world of virtual medicine, video visits can temporarily allow for follow-up of patients and allow them to decide in a more non-urgent manner regarding their traumatic injuries. This would allow them to use a more analytic system two thought process rather than committing to a decision in the office if they don't feel ready to do so. The next topic that I think there's room for improvement for allowing for consistency in shared decision-making is guideline adherence. And multiple studies suggest that there is poor adherence to guidelines in the AAOS clinical practice guidelines in the field of orthopedic surgery. Investigators out of the Rothman Institute found that there was extremely inconsistent adherence of upper extremity surgeons to clinical practice guidelines at baseline. And time, particularly in the setting of a traumatic injury, patients feel an urgency to come to a decision as soon as possible. This invokes a System 1 type fast thinking rather than a more thoughtful System 2 approach. And although most evidence suggests that shared decision-making requires more time, most 15-minute encounters do not necessarily allow for patients to have adequate time to come to a conclusion, particularly if there's a lot of nuance to their discussion. Patient education and word choice. It's important when talking with patients and allowing patients to come to an unbiased conclusion of allowing for a dispassionate discussion of options, as clearly patients are subject to bias, heuristics, and framing effects, as demonstrated in the prior studies that I mentioned. Avoiding a term like a need for surgery can be helpful unless there is an absolute indication to operate. Countless patients leave shared decision-making discussions feeling that they need surgery when the indication is relative, and they subsequently do their own research and lead to more confusion as a result. And as a reminder, framing effects are not just present in the studies of psychology. In our field of orthopedic surgery, a study published out of both UCLA and University of Pennsylvania, investigators asked patients if they would pick therapy or surgery for post-fracture arthrofibrosis. Patients picked surgery significantly more frequently when surgery was presented as a means for avoiding a loss in motion, and they picked therapy more frequently when surgery was presented as a mean to gain motion. So I think the main lesson here is to be absolutely sure that the evidence is clear when we tell patients they will lose function with non-operative management, as they will otherwise take risks that they may not otherwise take with surgery. From a financial standpoint, aligning incentives is important if we wish to facilitate shared decision-making. If physicians and institutions were reimbursed by injury rather than by surgery, I wonder if the incentive to operate would be flipped completely. Similarly, in institutions and healthcare models where OR access is limited, physicians try to keep patients out of surgery. But in the ideal world, physicians and decisions would be made by patient preferences rather than resource sensitive preferences. From a medical legal standpoint, patients with traumatic injuries and physicians caring for them have aligned incentives in terms of trying to help their patients recover from an injury and avoid lasting dysfunction. While large studies on shared decision-making have not yet demonstrated if this is a protective or predictive process for litigation, changes in medical legal systems can allow for minimization of extra tests and procedures that may not be consistent with patient preferences. And patient and physician education is important, I think, for this, if this is important for us. So many orthopedic surgeons lack an understanding of how to actually engage in shared decision-making or have received insufficient communication skills training in medical school and residency. Not surprisingly, orthopedic surgeons have been found to do a poor job comprehensively incorporating all elements of shared decision-making when discussing with patients. In Norway, where patient-centered care and shared decision-making have been mandated by law, investigators unsurprisingly found that when looking at physician encounters, physicians who had been trained in shared decision-making were much better able to adequately involve patients, and patients left their encounters with less confusion. So in theory, training should help trainees, both residents and fellows, and healthcare professionals to develop an empathetic understanding of social and cultural identities and allow patients to better participate in shared decision-making. Better shared decision-making training can help us become better shared decision makers. So briefly, in terms of conclusions, as I want to leave time to hear your thoughts, shared decision-making is here to stay, and this is partly because of its associations with higher patient satisfaction, and partly because this is an important goal of our American healthcare system, and this has been present for the last 4 decades. Secondly, patient and physician decisions can be impacted by heuristics and framing effects. And finally, there's room for organizational growth to support shared decision-making, particularly for patients with traumatic injuries. patients with traumatic injuries are at risk for making hasty or System 1 decisions, and we should find ways to support patients to be more analytic and come to System 2 decisions to hopefully improve their satisfaction with our care. So thank you, and I welcome any questions and comments.
Thank you, Dr. Lalchandani. That was great and very interesting. Dr. Immerman had his hand up quickly.
So, so first of all, I'm very troubled by the fact that apparently I'm not in the top 5% of surgeons. But that leads me to think, if all of us start believing that we're all on average, just average, what is that going to do to our, morale and ability to do what we do and kind of just overall happiness? Is that just human to think that we are good at what we do?
Yeah, I agree. I think that this is the challenge of this topic, is that there's so much literature and not a lot of concrete science. That's why I think, looking at psychology studies can be helpful, because is more transferable. I think that I agree. It's human. If 90% of drivers feel that they're above average, that's a human concept, right? But I think the main question is not about our morale, but about what is best for our patients, right? I think that, I don't know if there's going to be an easy answer about what's the best sort of treatment for our morale. But I think that, I think the concern is about overconfidence, right? I think being confident is important to being able to successfully carry out a procedure. But overconfidence can, cause, physicians and patients to feel like they can make an improvement in a sub-millimeter difference, when maybe the reality of, surgical instruments and our abilities is, less precise.
Thanks so much, Dr. Lalchandani. In one of your slides, you talked about taking the time pressure off of the shared decision-making process. I personally have noticed some providers will essentially, there's not really a team talk, but they present the options talk, and then the rest of the shared decision-making occurs asynchronously, where they say, think about it, and then we'll bring you back, and then talk about the risks and benefits of the surgery you've chosen. And I'm wondering if you came across any studies that talked about how well that works, or if you have any personal opinions on this kind of asynchronous.
Yeah, I think that's a good point, and I think that works well for for elective scenarios, and also for semi-elective sort of traumatic scenarios that can be managed as an outpatient. I think the challenge is the example of the concern about a digit replant, right, where you have to make a decision while you're inpatient. I didn't see any specific studies comparing those options. I think the consensus was that we can use technology such as video visits or, asynchronous decisions to allow patients to take off the time pressure. But I think that is more, definitely that's more resource intensive. That requires, a second visit, by the patient and the surgeon to, revisit everything, right, and address further questions. And so I think the next challenge is, how is our healthcare system going to support that?
Yeah, the healthcare system supports that because we get paid for that second visit. Yeah, so they're fine with that. So you said limitation of choice is one of the drawbacks to this. And how do you recommend counseling patients when realistically the option they want, whether it's an injection, especially a fancy injection, or surgery, like they want a meniscus debridement in the setting of arthritis, the literature strongly supports exactly what they don't want? How do you recommend having that discussion with patients without bumping up to the paternalistic, you're not getting that?
Yeah. I think that's another challenge. I think this is a one of the subtle sort of problems of when we say shared decision making. I think that we say we want shared decision making, but we also have guidelines and sort of resource utilization that we want to try to balance, right? I think, I don't know if, I think this is I try to stick to sort of steps for, that we can all implement, because I think that these larger policy changes are outside of necessarily any one of our grasps. But I think that when reviewing the literature, it seems like, I think if there's more consistent adherence to guidelines, I think that can help offload that pressure, right? If no one in the world is sort of, doing it, is doing a meniscus surgery for an arthritic patient. Yeah. But that wouldn't happen, right? And so I think that adherence to guidelines can help with that process.
Well, just to follow up on that, So the first thing is I support shared decision making, but I think that part of the reason that some surgeons aren't good at it is disempowering, and that's okay. Most people in the audience would say it's good to share the power with the patient. At the end of the day, the patient has the risk. So I agree with that, but it's also devaluing, and I struggle with that. It's a little bit like a lot of the other sort of things that are being pushed on us, and everybody's jumping on it, and everybody's writing papers about it, like zero harm. Zero harm focuses on all the harm we create, not on all the benefit that we create. And it's very undermining to us. So there's got to be a balance where sometimes you don't have a shared decision. That's sort of what Brian is saying. There are some times where a patient may want something that simply isn't indicated, and you can't engage in a shared decision about that. At least I don't. If somebody wants something and I don't believe in it, I'll just say, see somebody else.
Yeah. And I agree with that.
And I just wish that we would not all run as a field in one direction and accept something without some kind of balance.
Yeah. And I think that adherence to, like, if there's, I think as surgical variability decreases, I think that the question is what you feel, is it, based on, general evidence, or is it based on, certain specific evidence, right? And so I think that if it's general evidence, and I think that, guidelines suggest that we should do that, right? Not do unindicated procedures. But it's challenging when there's clinical equipoise, right? Because then you feel like if they were to have seen someone else or gone to a slightly different hospital, they'd get a completely different treatment. And I'm not sure it's fair to withhold that treatment.
Oh yeah, and let me tell you, when there's equipoise, I love shared decision making.
Yeah,
because I don't know what to do.
Yeah,
and so I want them to engage.
Yeah.
Great talk. My question is, how do we incentivize this process? Because a lot of the incentive is towards decreasing the time with the patient, right? Seeing more patients in clinic, making a quick decision. Surgery makes more money than talking to the patient. All the factors are, let's just quickly make a decision and move on. And how do we incentivize getting more time, getting more than that 15-minute visit?
Yeah, I think so number one, obviously from a policy standpoint, I think that, changing our models could be helpful, right? I think that the consensus is that fee-for-service is not the best model for engaging in shared decision-making. I think that, as Dr. Feely suggested, and I agree, I think using sort of telehealth can allow for patients to come to a second decision, allow for a less urgent or less strained decision-making process, and also allow for reimbursement for that. Because at least for right now, that is, an acceptable means. And I think, number one, it's providing patients with a valuable sort of time with their doctor and engaging in these discussions. So that's sort of one small strategy, but I think fairly, larger scale changes would be needed if this is important to us as a community.
So, hey, I really enjoyed this. Anchoring is a really powerful concept, and there's a lot of the concepts you talked about are very useful. I'll give you a little anecdote. Kevin Bozek, whom I'm surprised you didn't mention, was super involved with the whole decision-making concept to begin with. It was introduced into orthopedics. And he gathered a group of patients and clinicians as a focus group to talk about how to present this material. And right next to him was a lady. And he presented this case about knee arthritis and was going around the room and put it to the patient sitting next to me, assuming that she would support this idea that everybody should be in the room to talk things over and go over all the risk complications. And she basically said, "You're kidding me, right? I have zero interest in that. I just want to make my decision. I don't want to hear about it." And she was and other people go, yeah. Pretty much every other patient. So this is an assumption that patients want to have access to surgery. So the other anecdote was that I was on the phone with a clinician explaining a very complex thing to my father last night, who's 91. And I was listening to this conversation, like, there is no way that without an MD degree, and by paying a great deal of attention, I could understand everything this man is talking about. And he was being very careful, very deliberate, not to go over anything too quickly. But it was a lot of information about multiple treatment options. And like, at some point, if it wasn't that I was on the call, my dad would have just had no idea what he was talking about. So there is this asymmetry in information knowledge, but also the ability to process information, contextualize it. And while I super support what you're talking about, I think it's important because the opposite of not doing it is worse. I'm curious, this is a question for you. How have you changed your practice now that you're actually attending with a busy clinic in terms of explaining to somebody that their 5 millimeter gap in the distal radius fracture probably shouldn't be treated? Because that takes a while.
So I agree. I think that obviously there's a huge gap in knowledge, and so I think one challenge is that I think the reason why this came to my mind is that we often say we did a shared decision making process and we do the treatment that we were going to do anyways, right? And so I think that and that means that if a patient is given is assigned to one specific person, they may get a completely different treatment as to what they may get if they were to see someone next door. Personally, I think that I've tried to use some of these sort of newer, technologies such as video visits, allowing for asynchronous decision making. I try to, and then I think the other thing is, this is particularly relevant for, future, residents at the end of their training. When you start practice, all sorts of people are going to be willing and hoping to help you start your practice and send you patients that they think need surgery. And this is a challenge is, do they really need surgery? And I think that, number one, the term needing surgery may be a little bit simplistic. But number two, I think meeting with them beforehand and not sort of just jumping to the fact and taking someone else's word for it is important. Because, a lot of these discussions are more nuanced than just, black and white decision making. So, yeah. So I think meeting with them beforehand, personally, rather than taking someone else's word for it, and then allowing for, time in the process, that would be the things that I've sort of tried to add to the process personally.
So you mentioned guidelines as one of the things that can help us here. And with all due respect to Dr. Shapiro, I think, there can be a lot of flaws to the guidelines. They're just as subjective to biases. As an example, recently there's a guideline that women 40 and older should be screened for breast cancer. And if you get into the weeds on that and start reading, turns out that screening for breast cancer doesn't actually change overall mortality at all, and barely, if at all, changes breast cancer specific mortality, suggesting that these guidelines are not really that helpful.
Yeah.
So, so I think I just wanted to say that we shouldn't just say, oh, now we have a distal radius guideline, or now we have a guideline on blank. We should just follow it blindly.
No, I agree. I think, and I think that depends on the level of evidence for it. Interesting when getting into the weeds of those specific guidelines, there's a stronger recommendation and a higher quality of evidence for not fixing older patients than there is for fixing younger patients. But I agree. I think that's, is that helpful? And then, you have to use your own sort of personal thought process. Like, is it a high demand patient? Is it someone that's going to benefit from this? Right. I think the challenge though, is if we don't use it, or if we say that they're worthless, then, is that certain variability that, like, if you were to walk into a hospital, in, Oakland compared to San Francisco, you get, 100% difference in treatment. Or if you were to, go to a replant center, you'd be maybe 10 times more likely to get your finger reattached. Whereas if you were to come to a non-replant center, you'd be 100 times less likely to have a replantation attempt. So I think that sort of variability we should, ideally should be try to limit, I think.
Just a quick question. So you really emphasized how words matter, how you communicate with patients matter, not only in decision making, but pollsters know this. You just flip a word and also the poll are 180 degrees. And when you're preparing for this talk, did you come across any best practices on how to train young physicians on how to communicate effectively? What beyond just the shared decision making, but is it modeling? Is it reading? Is it, observing? Is it coaching? Because, that we struggle with that, because especially in the clinic setting, oftentimes trainees are in the room with the patients themselves and not actually, coached along.
Yeah.
So we want to do something that is effective, that goes beyond decision making with just communication skills, because there's certain phrases, like it drives me crazy when somebody says you need a hip replacement. I say, I don't need a hip replacement. I'm going to tell you what you can expect from a hip replacement. You have to make the decision, right, based on the pros and cons. So that's just one example. And phrases that are reassuring to patients. They like to hear if it's a cliche, but if I'm making the same, I'm telling you the same thing I tell my father type of deal. So did you come across techniques that you would recommend for trainees to learn some of these skills?
Yeah, so I think one, I think really pertinent and interesting thing I saw was we have, and this is consistently across medical training and even internationally, in medical school, there's consistent sort of training on communication and like how to talk to patients. And there's tests on how to do so. And I think as we progress in residency and fellowship, that's less emphasized and is sort of more of a trial by fire or a practice it, and then you'll get better at a model. Right. And so even, I think in European countries such as Norway, where it's sort of mandated that people participate in this type of decision making, they found that there was limitations in that sort of postgraduate training as to when there is a difference that they notice. As to how and what terms, I think that one that you mentioned is, this is how I treat myself or my family. I think it's helpful, but I think that can also bias people because, I think anecdotally, I'm sure we've all seen patients have different preferences sometimes. And when I'm taking care of an athlete and I'd say I wouldn't, do surgery for this, and they're like, well, my goal is to get back to sports immediately. I think that it's kind of hard to argue with that, right? So I think there is, I think it's a good strategy, but that's limited. And I think that in terms of how to, best teach it, and I think that I think the scenario that I saw was looking through even just something like going through the steps of a decision-making process and being sort of thoughtful about it, I think as they, subsequently when studied, physicians were more likely to engage in this, shared decision-making model. Obviously, that sort of study is biased by the fact that they trained people and tested people on the same model, but I think that can help. Does that make sense?
Yeah, it does. I'm just trying to, obviously, the level of skill that people have as a medical student when these initial skills are kind of tried to be taught, there's wide variability in, how effective trainees are and attendings are at every level. And some attendings are really good at that, and some attendings are not as good at that. And so it's, there's a lot of, you talk about spread and, intention to do surgery. There's also a lot of spread in communication skills. And I think that we could all get better at communicating with patients. And so I think it's an opportunity, and I don't think we don't spend enough time doing it at the residency training level. Yeah. So I'm just wondering how to do it in a cost-effective way, because we can't, and in a time-effective way, because we can't coach in the same way that you would be doing us in medical school.
I think the one study I saw was sort of in a lecture-based format. They just went through slides on shared decision-making. So that's one strategy. I think another one that I thought about when thinking about this problem is a lot of times it's the inpatient shared decision-making that's on a schedule. And a lot of times, particularly, in residency, if you see the patient overnight and the decision is made the next morning, you actually miss that discussion. And so, I think obviously trying to take the time to observe that can be helpful, though obviously, time is always a limited value as well.
All right. I think we will wrap up there, but Dr. Lalchandani, thank you again so much for presenting today.